Hi, I am Dana Gelb Safran, and I'm head of measurement at Haven Healthcare, which is a joint venture of Amazon, JP Morgan Chase, and Berkshire Hathaway. I'm also on the faculty of Tufts Medical School. And I'd like to talk with you for a few minutes about payment reform and its potential impact on health disparities and health equity. I think a lot of questions and concerns have been raised about how new payment models may potentially make health disparities worse. And also, more recently, with the onset of COVID and new care models that are highlighting the use of virtual care, how these care model changes may also potentially exacerbate health inequities. And while we have mountains of evidence of health disparities and their occurrence in the US, there's been very little evidence to date about anything we've been able to do to close those gaps. What I want to share with you is some encouraging findings from Massachusetts and payment model reform that actually help to close disparities that have been long-standing. And these stemmed from the Blue Cross Blue Shield of Massachusetts Alternative Quality Contract, or AQC, where a 2017 study led by Zuri Song of Harvard Medical School and published in Health Affairs in January of 2017 showed that the Blue Cross AQC was actually narrowing the gaps in quality received by patients from lower socioeconomic status areas relative to those receiving care from providers serving more advantaged populations. And the mechanism for this was fairly straightforward. Under the AQC, and largely because of the population-based payment and strong incentives around quality, outcomes, and care experience, providers were freed up from the usual one-size-fits-all approach to delivering care and began to really think about the individual patient and what was needed to accomplish good results for that individual, given their life circumstances and their health situation, and began to provide care that was actually truly patient-centered, drawing on new staffing models and new care models. And what the Harvard Medical School study found was that as a result of this, quality improvements among those serving more disadvantaged, socioeconomically disadvantaged populations were occurring faster and with larger improvements occurring than among patients being served by providers serving wealthier populations. So this is a promising finding and actually helps us to consider that we should not be adjusting away differences in population as we measure performance, but in fact should set a similar bar, the same bar, regardless of the population, but potentially pay differently for those who may have a population that requires a different level of resources to achieve success. So I'd love to engage you in that conversation and also to get us thinking about the recent changes in the care models that we see, which happened so quickly with the rise of virtual care and its prevailing use now. I know there are a lot of concerns about how this could contribute to further disparities of care, but let's consider how this, together with new payment models, could actually help us to accelerate and closing of the gaps in health and healthcare quality for socioeconomically disadvantaged populations or racial and ethnic minorities, any of the long-standing disparities that all of us who are here today are concerned about. I look forward to talking to you more about this and hope you'll join me for our breakout session. Thanks very much.